Now, good afternoon, Ms Barami.
Good afternoon, my lord. This afternoon we have Mr Adam Stachura of Age Scotland. His witness statement reference for the record is SCI WT 0214502.
Thank you. Good afternoon, Mr Stachura. Very good. Now, when you're ready, Ms Barami.
Thank you, my lord. Mr Stachura, good afternoon. You've previously given evidence to the inquiry, but I wonder if you could refresh everyone's memory as to your role at Age Scotland, please.
Yeah, of course.
And if that was different during the pandemic, what you did at that point.
Very good. So I'm currently the Associate Director for Policy, Communications and External Affairs. During the period with reference to this pandemic, I had the title of Head of Policy and Communications. Broadly speaking, it kind of does the same thing, but there's more organisational responsibility now. During the pandemic, though, I was very heavily involved in the kind of operation of the charity, of how the learnings from our national helpline were being fed into government or to other agencies, understanding the views and needs of older people, and being able to use the department I was supporting to help make sure that older people had the best possible information as far as we could see about the pandemic and how they could navigate that.
Thank you. Now, I want to start with consideration of rights by the government. Can you expand, please, on your view as to whether and how the rights of older people were considered in the decision-making processes regarding COVID-19 guidelines and restrictions?
That's a very good question. It's quite a difficult answer because I don't necessarily believe it was entirely clear how they would, on their own, be explicitly regarded. There's no doubt at the beginning of the pandemic that older people were very much in the public's mind in terms of those more likely to be seriously unwell or die from the virus. And indeed, at the beginning of the pandemic, the Scottish Government in particular, I think, were very good at, talking to us, looking for solutions and looking to the future. So, for instance, support for our national helpline, the conversations we had in early March, before lockdowns, they had come to us thinking about, well, what might we need if, for instance, as we found out, locking down, and what will people need that is offline? And as they already, to some degree, supported financially the operation of our national helpline, the conversation went into how we could scale that up and how we could be a useful and helpful conduit for public information about the virus. I think at the beginning there was certainly a focus on what older people might need. And I think over time there was certainly numerous touch points with government on issues that arose, whether it was because of the information we supplied them that was coming in volume from older people across Scotland. But I think it is quite hard to see if there was anything particular over time just for older people. I don't necessarily mean that older people they clearly weren't the only group of people in the country who were affected by this by any stretch. And I think everyone's experience of the pandemic will have been quite different. But at the start, I think there was good consideration in a sense. And over time, I think with the issues that we raised repeatedly, it was sometimes quite hard to see the outcomes of that and where that kind of fit in the activities of government and how they're trying to support the country.
Thank you. And in your experience, were mechanisms in place to ensure that equality and human rights considerations were embedded in pandemic-related policy in respect of older people?
I think that's another good question, and it's hard to see. It's hard to see from a charity or from another organisation to what degree that worked in reality. There are mechanisms in policy making and how government delivers services, such as equality impact assessments through the public sector quality duty, for instance. But actually, in reality, often an EQIA, which is a quality impact assessment, sort of comes after the policy has been decided to almost then map out to what degree it will impact people. And we still see this to this day, that EQIAs are pretty thin in terms of what they do, and they broadly look to ratify a decision that's already been made, and no one's there checking the homework. So there are mechanisms in place, but how well embedded they are, I would, personal and professional experience of it would suggest that they're not early enough in the stage, and they become a need to do later on down the line.
Thank you.
Tick box.
Yes, no, Lord Wilford, yes, I think our experience of this to this day is tick box many a time. I think, to be fair, the Scottish Government on some occasions through the pandemic period sought our views on potential policy issues to look for how that might impact people, and that will be from specific units within the government tasked with looking at these things. But I can't imagine there's many people who suggest that an EQI is not a tick box exercise, and it's certainly not marked by anyone else, and indeed challenge to it is almost impossible. And to this day, I'm currently engaging with a bit of a battle with an integrated joint board on a EQIA proposal where something is seen as a critical risk and substantial risk to people, yet the mitigations are about as thin as they come. So the EQIA exists, but in actual fact, it's happened. The thing has happened, and it's part of the pack, part of the papers. I believe that becomes more embedded in our policy making. It is the last stage, and not an early stage.
Thank you. Now, in your statement, you raise the question of whether the right to life simply implies not dying, or whether it should encompass the right to a good quality life. Do you think that distinction was reflected or not in the Scottish Government's approach during the pandemic?
I believe that depends on what issue is taken regard of. I think with regard to lockdowns, for instance, I can imagine as the easing of those national restrictions happened, there may have been more of a thought around, okay, we must protect life, but actually, how long is that going to be impacting somebody's quality of life, right to family life, other things which are embedded in care homes? I don't think it was regarded at all. Not least in terms of there wasn't enough action or activity or demonstrable kind of substance behind the need to stop care homes being locked down, to allow family, to allow carers to kind of go in and see their loved ones, to support them, to improve their quality of life. Because as we saw, and everyone around the country will have seen pictures of this, of people having to communicate through windows or out in gardens if they could, the deterioration of people living in care homes was significant, and that happened quite significantly fast. Sorry, that phrase was slightly clunky. And I think the reason for putting this in the witness statement was that it is unclear at what point anybody with decision-making responsibility decided we must do everything in our power to make sure that care homes can open and support safe visiting, and to manage the risks that come with this. And I don't think that has happened at all. In actual fact, a bill has just been passed in Scottish Parliament just last week, which takes into account of Anne's Law, which came from this. And how many? That's 5 years since. And I don't understand why the government have taken so long to be able to embed that, even so long after the critical moments of the pandemic. So I don't think we ever saw that consideration with that particular issue at all.
Do you have any thoughts on specific changes or reviews that you believe are necessary to ensure that the rights of older people are protected in the future?
I think there are some pieces of work which could happen in the health sector. I think that there should be a significant review of how do not tempt resuscitation is conducted or discussed with people. I think that needs to be about the communication, about the understanding of the public, and co-produced as well, so people can better understand what it is and actually feel empowered. I believe that how do not tempt resuscitation discussions were approached in Scotland was terrible, actually. And I, to some degree, I can understand in early stages panic around what to do, that their health service are trying to kind of just really understand what might be necessary. But it was really clunky, that people were phoned up out of the blue, asked to sign up to something that they had no idea what it was. And ultimately, to what degree, I think in terms of the review of this, is to look at to what degree have those discussions led to an impact on the care options or health care options that somebody received. And I think a review of that is absolutely necessary, which I'm delighted that it's part of the terms of this inquiry. It's something that we had actually called for while the inquiry was being set up. There will be more, but I think there are... But how, I mean, there's more in my witness statement about, say, digital exclusion and how public services have moved, expedited by the pandemic, sometimes by necessity because we couldn't do face-to-face or, even having telephony services as such because the technology wasn't there. I think we need to have a review over whether we're getting the best public services for people who need it. I think that digital transformation of public service is a good thing, absolutely. I think that can absolutely support better operations, but that kind of front door for people, however they need it, is important that it's as they need it. They're public services. And I think that we've moved so far down a line on a digital first approach, we just forget the 10 or 15% of the public who just cannot use them effectively. Even if, for everyone who's older that's online, about 4 in 10 are demonstrably unsafe operating online. They don't have the confidence, they don't have the skills to navigate. So sometimes we can think of digital inclusion in terms of the number of people who are connected to the internet, but there is a significant number of people within that group who are really not safe, really don't understand how to get what they need out of it and face so many barriers. So I think they need to have a little bit of review about how we access public services for people. And it's not just about a small generation of people right now. I think with disability, with an increased number of people projected to be living with dementia in the future, so cognitive decline, there'll be lots of other people who will struggle to keep up or navigate with our public services with that digital first approach. So I think there are two things off the top of my head that might be helpful to look at.
Thank you. And you actually speak very powerfully about digital exclusion in your statement. Do you think that move towards digital-only access to public services undermined older people's human rights, particularly with access to information, health and social services?
Yeah, I think there'll be experts in human rights to be able to give the exact level upon which that will impact them. But broadly speaking, I do think it was the case. I think if we looked at early on in the pandemic when, as an example, when the social care packages were being removed overnight almost because the care providers were unable to facilitate them, the only way that people or their families could then communicate with anybody in a council, for instance, was through the internet, through email, but it wouldn't necessarily land at a person's inbox. There was no personal responsibility for it. And complaints about removal of services would go back to the people who decided on that in the first place. So I think it was really hard for people to access the things that they needed to stay well and, quite frankly, stay alive. And it was a difficult time, of course, for people, and having to navigate a new system, to not get the answers that you need, to not feel that there's somebody hearing you, I think, was incredibly difficult for people. What impact that's had on people's lives, for instance, I think that remains to be seen. But our instinct is that there will be a considerable number of people who had social care packages turned off, who died as a result of not getting the care they needed, and not being able to communicate with somebody, not being able to challenge things, not being able to seek redress on that, and the difficulties that are put in place, I think, has been quite a shameful moment. I don't know at that moment how you'd have fixed that, but I think that inability for people to engage in the way that suits them, that feel that they're being heard, has had a knock-on impact on people's lives today as much as it was back in March, April, May 2020.
Did Age Scotland receive any feedback from older people on that, indicating that they felt discriminated against or left behind?
I mean, yes, and we still do. happens regularly. It's not a challenge just for the pandemic, that our helpline will receive calls on a weekly basis from people who are not online, don't feel safe online, and don't feel that they're able to engage properly with public services. That when local council offices, for instance, weren't open or stayed closed for so long, and in actual fact have just ceased to exist, that they have nowhere to go. People who rely on cash, for instance, to pay their bills, to manage their own finances, of which there are many, many people who are doing that. And I think it's becoming more prominent now. We're struggling to pay the bills that they're due, to get advice. We see that with the removal of bank branches as well across the country, but getting that kind of face-to-face advice. And there have been great examples, sad examples, but great examples in terms of demonstrating this, of people who are just trying to access applications for a blue badge because they're disabled. They're being told by the local authority you can only get that online. So when they call up the main number, they speak to somebody, it's only available online. No support, no help to get a copy of that. They'll call us, we'll try and help them out, we'll get a copy of the form, or we'll speak to the council and ask them, look, why can't you fix this? And it turns out there is a fix somewhere, but the people have just they've met these barriers. So the very simple things that people should expect in terms of what support is available for them, they're finding these barriers, and people just don't feel heard unless they're online. They don't feel that they can feel disempowered. And if we've got a society and our public services and life that is almost wholly digital, it's quite easy to see why people will feel disconnected, feel more lonely, just disenfranchised. I think but it comes through regularly.
And were there particular groups of older people who were disproportionately affected more than others by digital exclusion? For instance, those from rural areas, low-income backgrounds, ethnic minorities, disabled?
It's quite hard to put a scale on that. I think there are definitely groups of people of an older age who would be disproportionately affected by this, particularly those who lived alone, on low income, have a disability, don't have family members nearby in that local vicinity, who would have had at the moment of lockdown, had no means really to go and buy or acquire digital devices, to learn how to use them, to feel that they were connected. We know now that about half of older people rely on their TV or radio as their main form of company in Scotland. These are kind of the simple technology that we have, but that's the scale of loneliness that exists. But these are certainly elements where you're more likely to be digitally disconnected if you're on low income, that you experience that kind of digital data poverty because you can't afford it, you can't afford to keep up. You maybe weren't accustomed to using it maybe through a professional career as well because of your whatever industry you're in or other reasons too. I think there's certainly older people from ethnic minorities who will have struggled early on. I do remember lots of conversations with older people from ethnic minorities about how eye-opening it was that once they had a smartphone, once they had apps like WhatsApp, for instance, they're able to make video or voice calls to family members in other parts of the world for free, and they weren't then paying extraordinary amounts of money to do so. So once people had access to technology and understood how to use things simply, it could really change their lives. But there are people at the beginning of this pandemic where life will have shut down, they didn't have access to things, and actually the means to adopt them and the means to feel comfortable with them were very, very limited indeed.
Thank you. Beyond digital exclusion, did Age Scotland hear from older people with literacy issues, sensory impairments, or people for whom English was a second language and who struggled to access or understand public health information?
I think we were very lucky to work with so many other charities during the pandemic, before it, during it, and since then. And there is certainly an example with regard to access to food, that we were working with a coalition of other charities such as Guide Dog Scotland, Royal Blind, and others who were showing what their kind of constituent base were experiencing with trying to access supermarkets, trying to access online shopping or not. And so hearing, particularly through those routes, coming together to try and explain to the government that we need to improve the experience of people who will face disability or frailty or other issues in their lives, to be able to access and navigate a supermarket safely. I think that is primarily where a lot of our information came from those close forged partnerships with others. We certainly heard from people through our helpline about who would have been disabled, about issues around DNA CPR. Again, they'll come to us either because they might have heard us on the radio or watched us on TV or in the newspapers talking about the issue, and therefore would call us to explain their situation. But I think for those who are disabled, that really rich information did come through those partnerships, and we could kind of work together to kind of identify what a solution for folks might be. I think there was a real challenge for older people from ethnic minorities where English wasn't necessarily their first language or particularly confident understanding public information. And a lot of that information has come since the pandemic. I don't think that we were overtly inclusive enough. We were as an organisation, but I don't think we were doing enough to support older people from ethnic minority communities. We're doing a lot more now, and I think that's really benefiting the groups that we're working with. They want to be part of what we're doing. We support and enable them. But the information that's come in since was about people who were on their own, who couldn't access information, they didn't really know what to do, and they had turned to drink and alcohol as a result to cope. And I think that was really quite remarkable to hear. I'm sure that happened for lots of people, but this was a very specific example of people who just felt isolated, they didn't feel that they knew what to do, and that depression, in a sense, had driven them to consume alcohol at levels that they were not normally doing. And there will have been, I think, good community-based organisations and charities who were really connected with older people who are from ethnic minorities, who speak in different languages at the time. But I'm sure there will have been a lot of people who weren't connected and don't know where to turn. And if we are broadcasting simple information to the public, which I think we did in Scotland quite well, or we did, the government did, the health services did, I don't think there was enough account for other languages, because you sort of had to go and ask for it after you've been told something in English to you can request other forms of information. BSL, I think, was quite prominent. It was good to see that on the Scottish Government's kind of daily news briefings. That was a regular feature. I think that was an important part. But I think it'd be quite hard if you didn't speak English well to know where to turn to get an alternative language format, unless it was through an intermediary or someone that you're working with. And that was quite hard when you're locked at home, whether you're asked to shield or whether you're feeling clinically vulnerable. You can't go out and about. You won't really know who to engage with.
And you mentioned the withdrawal of certain social care packages and other services. Can you speak to how the sudden withdrawal or alteration of services may have particularly affected older people with other protected characteristics? For example, an older disabled person who was also a carer for, say, their spouse or someone from an ethnic minority group?
That's an important question. Early months of the pandemic, as social care packages are being removed across the country, the reliance on family members to then fill that void was becoming more prominent. But indeed, those people who've been asked to, can you now care for this person who's in your family, almost a bit of guilt. Well, you live quite close. Can you step in? They themselves might have been clinically vulnerable to the virus that they had been asked to shield, that they were very, very nervous about transmitting the virus to the person that they loved and cared for as well. So as people were asked to isolate, they didn't have the ability to do this. And indeed for folks who had mobility challenges that didn't have access to their own car as transport, travelling the distances that were required to do that would be incredibly challenging. I remember conversations through our helpline for people who were stopped by the police in early stages because they were travelling to deliver care, and they're being questioned by the police about why you're going where you're going. Can you prove that you've got to deliver care and not offer some other journey? And I think people felt very nervous about leaving their own homes and feeling that they were empowered to do so. But I think for folks themselves, they will be looking after their own health, people they also lived with, and finding that they'll be ill prepared to to effectively look after somebody with potentially complex needs. It's a really difficult job to do, and the default that, well, someone else in your family will be able to look after you, I think, was unfair to make. I say that, though I'm not sure what the alternative was, if there was enough care packages, but I don't think we did a good enough job of trying to support as many people as we could. Things were turned off and not think about how we can do something supportive for folks.
Thank you. Now, you've touched on DNA CPR a couple of times, and in your witness statement you described troubling accounts of unsolicited DNA CPR conversations. Do you believe that the way these conversations were initiated represented a violation of the right to autonomy or dignity under human rights principles?
Yes. I think DNA CPR is a really interesting topic in that it's to do something on paper, something very specific. It's about what happens if you essentially stop breathing or your heart stops. But I think it was being used in a way which was different to that. It was almost to identify people who were more likely to need further treatment, and then think about the kind of options that are available to them. I mean, essentially, I was speaking to geriatricians recently, and they feel that the whole situation across the UK, I hasten to add, was horrible for clinicians having to have these conversations. But also for the older people who are receiving them. I think they don't feel that the health service in general did a good job on that, and that it did result in people's loss of dignity here. They sort of made a phone call out of the blue to essentially say, let's start thinking about death here. And it was live. This is a live issue that's in the news every single day, and people are worried about it. I think that we had lots of calls from people who were very angry about it, didn't know where to turn, didn't know what they could do, realised actually they don't sign up to such a thing. A clinician makes a decision. There's almost a discussion about it that has to happen. But more often than not, we found in cases that came to us, the discussion never actually happened. They found that they had a DNA CPR decision made about them, and sometimes a box was ticked to say a conversation was had with the patient, and it didn't happen. And I think that demonstrates a significant loss of dignity and autonomy in someone's own kind of personal healthcare needs. I'm sure in a different period of time, if there were proactive conversations about this issue in a different way, at the right moment that both parties feel empowered to have conversations, DNA CPR is a different conversation entirely. But the examples that would come to us absolutely demonstrated that, from those examples that came to us, that it wasn't just about what happens if your heart stops. It was more about what options medical treatment will be made available to you. And it was put to me by some geriatricians that DNA CPR is essentially treatment for somebody who's dead. It's not something for somebody who's alive. And so it's not to take away things that will keep your heart beating or keep you breathing or keeping you alive. It's very much about, if these things happen, you've said you want to be brought back, and we'll do our damnedest to do so. So it's a treatment for those who are no longer alive. So I think I still get really quite angry about this 5 years later. It was an issue which all the people that we spoke with were so worked up about, felt that they were being written off. And we've never really got to the bottom of why and how this was happening and the scale of it and what it meant for people's lives, fundamentally.
Yeah. And I wonder, was there any demographic pattern in the calls that you received about this issue? For example, were older people with cognitive impairments telling you more about this, or people in care homes? Was there any pattern, or was it quite random across the older population?
You'll have to accept my memory of the time. What we didn't do in the sort of the heat of the moment was capturing too many of these details. Our helpline before the pandemic would receive about 80 calls a day. At its peak in the first few months, it would be north of 800 a day. It's a huge volume of calls. The thing that struck me was there wasn't a pattern. It wasn't. I'm not saying that if there was a pattern, that would make sense. The thing that struck me is that people would self-identify as being in good health, that there might be something. They might have had a condition which is well under control, that people might, as on one occasion someone had hearing loss, and is that the reason why? And I'd seen examples of DNA CPR forms where it was handed to somebody and the reason for it was because of communication difficulties, because they were hard of hearing. I don't think there was necessarily a pattern. I understand it's more about linked to those who are maybe more clinically vulnerable, whether it's due to age or other things, and not an opportunity, the wrong way around, but GP practices and others were part of that discussion and will have been thinking about anticipatory care plans for people, and DNA CPR is part of that. But I don't think there was an obvious pattern apart from you're maybe older, you're maybe more clinically vulnerable, and and we've got a phone number for you and we can contact you. I think that's why a lot of people were so angry about it, because they felt that they weren't at any stage close to death. They shouldn't be written off. They had many, many years left in their lives, but a phone call comes or a conversation happens out of the blue, or they leave hospital for something unrelated, and a DNA CPR decisions in their discharge papers, and just felt it was completely wrong. And I can absolutely understand why that would be the case, why they would feel it was so wrong.
Thank you. I want to move on slightly to equality in health access and screening. In your statement, you highlighted that delays and digital barriers to routine health screening, including breast cancer screening for over 70s, there were significant issues there. Do you believe that these barriers amounted to age-based discrimination in accessing healthcare?
Broadly, yes. I think that we see ageism in our health care service in lots of different places. I think DNA CPR, of course, I'm not going to dwell on that, was one example, quite an egregious example of that. But there were certainly cases that came to us from older women who were no longer able to self-refer for breast cancer screening because they're over the age of 70. At that point, over the age of 70, Lord Brailsford, you have to start self-referring for breast cancer screening, but that service was shut down, and the whole service was shut down for a number of months. And on its resumption, it was just for those people who are being invited under a certain age to attend for screening. It took a very long time for that self-referral part to open again. And in our mind, and from talking to medical experts and from other charities that were more invested in this, that they had far more expertise than us, also felt that it was wrong that people over a certain age were not allowed to self-refer, particularly people who might have a history of breast cancer or whatever. That age of 70 pretty much cut them off. And I know I've said this the last time I was here, that there are family members, and there have since been family members, who have died of cancer when something's been caught very, very late. And there will be a knock-on impact because of the pandemic on catching severe illnesses like this, and what options are left for people. So it wasn't just our feeling that, for instance, on breast cancer screening, that it was the resumption of self-referral happened too late. And I think, I can't the exact date here, but it will be at least 18 months, I think, from the start of the pandemic that started again. From our own intelligence, I think that's slightly contrary to what might have been on a government website, for instance, but certainly the conversations that we were having. But we see this as well with regard to vaccination programmes for other things, that, if you're over the age of RSV, for instance, vaccine recently, I think it was over the age of 75, that you weren't able to get it, 80, but there was a very short window for people, but older people aren't regularly included in medical research. Therefore, we can't really tell the efficacy of certain things. So there is an ageism that's built into that institution. Not necessarily intentional, but it's certainly there. And I just hearing from people about their anxieties about their own health, about how long it took and has taken for the health service to resume in the way they felt they need it, and to better manage their own conditions, or allay the fears that they have. I think it's very testing for people. And that, we're years later, we're still dealing with that impact of the health service being shut down essentially for a period of time at the beginning of the pandemic.
And do you think that more broadly than cancer screenings and that kind of terminal illness, do you think more broadly it affected older people's right to preventative care during the pandemic?
I think it's really hard, I think, to see a GP or access GP practice, which will have been, for a lot of people, the primary way that they'll either had a medicine review, that they'll have been able to check in on conditions to catch things early. And I think as we've seen with more and more people going to A&Es, for instance, to have undertake routine medical care, that access in the first instance is still a challenge today. We're quite worried about, the long waiting times, for instance, for replacement of knee and hip operations. Fixing that is hugely preventive for somebody's health. And, the longer people wait for this, potentially they pass a point of almost no return medically, that the kind of doing this operation will have significant risks to them that might not have the impact anymore, but folks will then have to rely on painkillers for their life that will have reduced mobility, that will increase their loneliness and isolation, that will have detrimental impacts on their mental health and then their physical health in other ways, that will probably require more social care than otherwise had been required. So I think these systems link together, and if people aren't able to access what they need when they need it, and I think, I say it's not as a doctor, thankfully, for all, but, knee and hip operations are fairly routine now. But it's 2 years waiting lists for somebody to get this, if they're lucky at times, or you spend a lot of money to go private to have something done in a very short period of time. So I think there are issues like that have not properly been resolved, and people will have taken, as we know from other people, the message of stay home, protect the NHS, absolutely literally. I understand this, I can't access this, I'm doing the right thing. And then when they presented themselves in health settings, that the conditions they have are pretty severe, and it's gone on too long, and actually the course of actions required to treat them is significant. Thank
you. Now, you've mentioned already in your evidence older people feeling left behind and written off, and in your statement you say that there was a huge negative shift in how older people felt about their lives. What actions do you think are needed to restore a sense of value, inclusion and trust among older people in Scottish society and in public services?
I obviously can't speak for every older person by any stretch. And what we know from our own intelligence and information and research is that there has been this shift in terms of the number of people who feel valued by society, negatively so. When we'd asked people in 2021, over 50s in Scotland, do you feel valued by society? 51 or 52% said they weren't, but it didn't mean that 48% said yes. It was something like 16%. The rest didn't really know. In 2023, when we asked thousands of people again, that had moved to about 2/3 of over 50s didn't feel valued by society. I think there's a lot in our public narrative about people who drain resources. We have language around delayed discharge, that people who are bed blocking, for instance. These people don't want to be in hospital, don't need to be in hospital, but they're being tarred as blocking the system. It's the worst possible thing for somebody's health to be in hospital longer than they need to be. For an older person that's in hospital for 3 weeks longer as a result of delayed discharge than they need to be, it can age them by 30 years. So there's almost a challenge for people in terms of how we talk about older people. We've seen this more recently with conversations around, for instance, the withdrawal of the winter fuel payment for people. Well, actually, you don't need this. Why are you getting this? You've got loads of money. Pensioners are really well off. Well, that's not the case. But half of Scottish pensioners have incomes lower than the income tax threshold. So I think the public narrative around older people is challenging. And that's not targeted at any other kind of age group saying this. It's just part of kind of built-in, I think, ageism, an older ageism that we face in Scotland and the UK and across the world. We've had conversations with older people being blamed for things, whether it was the Brexit vote, whether it was not having Scottish independence in a political sense, whether it was we were locked down for too long to try and save older people. That is just horrible to hear for folks and feeling that they're some kind of problem. And at times we've seen in kind of health discussions on things that people are expendable. I think that has not been helped. And of course, I think in terms of that negative shift, not being valued, people have really struggled with finances. We've got a high level of financial insecurity in this country amongst older people. Poverty for women in their late 50s is about a quarter, I think. So going into that kind of state pension, we're a really difficult place. So people don't feel that life is very good just now, and I think that's reflected in the research that we've undertaken. I don't think I'll be contrary to anything else that anyone else will have.
Thank you. I want to ask you a bit more about isolation. You've touched on it already, and you've touched on the helpline, but you mentioned in your statement that the Age Scotland helpline became a lifeline to many people who were profoundly isolated. Did you see that isolation as infringing on older people's right to family life or participation in society? And secondly, was there any engagement with government on how to mitigate the long-term equality and human rights harms caused by isolation?
The huge scale of loneliness that affects older people was apparent before the pandemic. There will be 1 in 10 over 50s and over 65s, you want to use that age group in Scotland, are lonely all or most of the time, suffer extreme and chronic loneliness. Around half will experience loneliness. The pandemic brought that into sharp focus, I think, for everybody, as we're locked down, as we might live on our own. We might have no one else around us if we've undertaken caring responsibilities, for instance. We have no one else to draw on. It's not improved, the position, since the pandemic for older people. I think with regard to that equalities and human rights lens that you're speaking of, I think that's in isolation. I think that would be probably more profoundly felt in care homes. There's an element where, if we needed to lock down and to be isolated for a period of time, then that was part. But it was restricted to a certain period of time. A lot of people will have not been able to get over that, of course. But I think that the human rights infringements for people living in care homes who essentially could have been locked away from others for more than a year, beyond that time, actually, is significant. And talking earlier on, I talk about how long it's taken to pass a law to embed the right to care home visiting. That isolation, that loneliness, the deterioration that people faced is profound, and it wasn't recognised early enough. I think it's taken a long time to recognise that, whether it's through public health, whether it's through the government, whether it's through whoever that has some kind of decision-making purpose there. To be fair to the government, Scottish Government, back in 2018, end of 2018, Scotland launched the first of its kind in the world, a strategy to tackle loneliness and isolation. Has been in the government's mind. We would talk about them during the pandemic regularly. There is a minister who has responsibility for loneliness and had been through that time. I think the question I have is, to what degree is that embedded across government? To what degree is that interest not embedded across public services and understanding that public health crisis that comes with high levels of loneliness and isolation? But it was certainly, with regard to the Scottish Government's Equalities unit, a big part of their work. And understanding that, I'm just not sure to what degree that was a primary focus of the government or other decision makers, whether it be in health or in or in other areas. But the Scottish Government did fund, during the pandemic, initiatives, projects, charities to undertake activities which will connect people. They had, on a digital front, they had, which is in my evidence, launched a Connecting Scotland programme, which would, support people to have a digital device, have access to the internet for a prolonged period of time. I think it was about a year. So it could overcome some of those challenges. And I think it was huge, tens of millions of pounds was invested in that over its lifetime. I think it was there in the government's mind. I just don't know we've really cracked yet how important it is to consider loneliness and isolation in our delivery of services and our policy making.
Thank you. I want to go back slightly to the loss of formal care packages and reliance on family. Do you think that shift disproportionately burdens certain types of family? And also, to your knowledge, was any assessment made by local authorities of the human rights impact on those families who couldn't meet care demands?
I think to take your last part first, I don't think so. I don't think it figures in the decision making. As I mentioned earlier on about EQIs, for instance,
Yes.
they are, I think broadly speaking, I'm fair to say they're passive thoughts. They're a necessary thing to do, and there are some examples I've seen in the past that there's very well considered work, but I think broadly speaking across public services, it's not. I'm not sure there was a really proper consideration. I think the impact on family members who not just were asked to care but felt they and obliged and wanted to care would be significant. I think people were thinking about, they weren't being selfish, they'll want to, but actually, there's hundreds of thousands of people in this country who are unpaid carers. I think it's over 600,000 who are unpaid carers, according to the last census, but I'm sure it's actually higher than that because a lot of people won't recognise what they're doing as unpaid care. They feel an obligation, they feel a sense of duty. The person that they love, of course they're going to be the person that cares for them. But it can be really, really difficult without some kind of safety net, without some kind of support, without knowing who to turn to for the things you don't know. And I think the pandemic will have absolutely drawn that out. That people are now just asked, well, whoever it is, your mother, your father, your auntie, your uncle, your wife, is no longer able to receive the care from professionals that they've received over to you. And I feel fortunate I didn't have to do that, and I don't know how I necessarily would have been able to deliver the right kind of care the person needs. And of course people will have been part of that care environment for people, but it'd be a very difficult job to having someone washed, dressed, taking medication. There's quite specialist things that'll have to happen, for people who might not be physically able to do that. But people will go on with it. But there'll be anxieties about whether they're doing it well enough and the impact on their own health, their own well-being without that extra support. And we still see this beyond this period of the pandemic where care packages are, I know that's not the focus of this, but up until the end of the last financial year, we're hearing examples of integrated joint boards reassessing people for their care packages, downgrading them from the substantial risk that they have to something less than that. But they weren't like Lazarus. They hadn't miraculously recovered. They couldn't possibly, but packages are removed, whether it's cost-cutting measures, lack of services that exist. But how on earth are people able to live some degree of independent lives, to be able to have a fulfilling life without that extra support? And I think that we have, through the pandemic and since then, fundamentally failed as a country to get to grips with how to reform social care to be as good as it can possibly be. I think we've lost that impetus, and it'll be very, very hard to get back.
Thank you. In your statement, you note that only 3% of older people feel it's easy to have their voice heard by decision makers, and only 8% feel politicians give due consideration to their needs. What practical steps would you recommend to improve participation and influence of older people in policy making?
I mean,
if any.
Yeah, there will be things. I mean, what I will say though, that's the experience we have of speaking to thousands of people of the age of 50. it might not be any different from any other age group, but I think it's quite profound how few people think that they are heard, whether it's in the policies that are passed and the challenges that they face and the solutions that they seek. One of the things that Scotland used to have was a dedicated named minister for older people. I think that was a really important signal. I don't think the reason why so few people don't feel valued is because that has been removed as such, but I think their kind of political signals are very important, that the political leaders are talking about the issues that affect people. I've got to understand them. And again, I go back to that point about social care and reforming it. You know, in a lot of the political battles on the National Care Service, for instance, it was hard to hear people talking about older people's needs in that. There was operational things, there was how general principles about how something should happen or not, but it was hard to hear that people had older people's needs first and foremost. The cost of living crisis has affected people significantly, but again, that's of all ages. There's no, in my mind, there's no people worse off necessarily, but individuals will have a far more difficult time. I just don't think in Scotland that we have enough policy making to support an ageing population. It's not just about having a state pension. It's not just about having a bus pass, which certain politicians have suggested that will be just plenty then, isn't it? You've got a bus pass, what more do you need? Slightly glib, I apologise, but that's some of the feedback you get. It's just, well, what more do you want? They're not seeing that the public services they require are in the state that they need, that it's harder and harder to get access to good quality healthcare and social care. And yeah, they're struggling to, hundreds of thousands of pension-age people in Scotland today are living in fuel poverty. But it's hard to find out what the Scottish Government are doing about that or saying about it. It doesn't feature in their narrative around fuel poverty, for instance. So I think it's hard, the reason for this is it's hard to see what proactive measures are there to try and improve older people's quality of life if their own experiences are so challenging.
Thank you. And you mention in your statement a lack of higher level or responsive feedback loop between Age Scotland and the government during the pandemic. What would an effective feedback mechanism look like, and what barriers did you encounter in establishing one?
I will say that the officials in the Scottish Government in the Equalities Unit, I think, were very good. That they were proactive in trying to understand the issues that were arising from our helpline. They were our conduit into government, partly because that's where we might receive government funding to something. That's where it kind of came from, and also where the older people's responsibility in government kind of sat. I think at that level it was good. What I think we found challenging was when we raised issues about the experiences older people face, whether it was about access to food, whether it was about DNA CPR, whether it was about creating an action plan for that first winter to support older people, it would take weeks, if not months, for a response from the government, from a minister. And I didn't understand that. We sort of had what I felt like a semi-direct line in through officials, but it would take, there's some occasions it took 3 months to get a written response, and the time has passed. I think our response to the call for an action plan for winter was put out in the beginning of October, and we got a response maybe in January. I just felt like there was more learning that government ministers could do by speaking to not just us but lots of other charities. I don't think we were unique in this that felt that that feedback loop was challenging. When we did have a fairly frequent opportunity to discuss matters with Christina McKelvey, who was the Minister for Older People and Equalities. But I suppose it was hard to see by those at the top in Cabinet, Deputy First Minister, either being appraised of these issues or seeking views. Wasn't meant in any kind of egotistical way that Age Scotland have the answers, probably far from it. But it was hard to see when we presented the problems that older people facing, sometimes solutions, to actually understand to what degree is that being considered by government. And it might be where it's at in government, where route in. I don't necessarily think the Equalities Unit will be first and foremost in the minds of those senior officials in the health department, for instance. And that's not to diminish the responsibilities and the expertise of those in the Equalities Unit, but I don't think it was maybe central to the Scottish Government's political activities. It just took such a long time to get answers. It took a long time to get responses. It took a long time to see any change. And I think that charities like Age Scotland and lots of others had so much good information about what life was like for people, the challenges they're facing, and would have been, I think, good to know that it was having an effect on their decision making. But I think that's the challenge I saw, and a frustration in our organisation and others about just the length of time it takes to get even a simple acknowledgement or response. You know, and the responses that will come back will be very, very technical, just quite defensive. That wasn't the spirit of the letters or the communication. So I think there was more that I think senior ministers could have done to reach out and be more proactive. And it might have helped their decision making, but I don't know. I mean, it might have. More information is better than less, I suppose.
I have one more question, and then I'll give you a chance to comment on anything that we've not covered, or highlight, anything that we've not covered. In your statement, you advocate for the creation of a statutory commissioner for older people in Scotland. What powers and functions do you think this role should have, and how would it have changed outcomes during the pandemic?
Well, thanks for that. I've been at Age Scotland since the beginning of 2018, and when I started, I was, discussions had already been happening for a couple of years about, well, Scotland should have a commissioner. There's a commissioner for children and younger people. We've got a huge population of older people, and it's growing. And what became apparent during the pandemic was discussions that I and our former chief executive have on a UK level with a coalition of other charities and organisations, which included the Older People's Commissioner for Wales and Older People's Commissioner for Northern Ireland. And what it felt like was that they, particularly the Commissioner in Wales, had more of a direct line into government and had a statutory footing. The Commissioner in Northern Ireland slightly dealt a really tough blow, and it wasn't really a functioning Northern Irish executive at the time, and was sort of tasked to doing quite a lot of stuff on their own as Commissioner's office, so didn't really have that same, at that moment, at a critical moment, have as much an ability as they would have on paper to raise issues and to investigate issues. For us, a statutory commissioner for older people in Scotland isn't just so much about tackling issues for older people today, but also those in the future, that they would be independent of government, that they would have the power to investigate, that they would be and compel public services to supply information or seek changes and be a convening force on those issues in a way that a minister on their own might not be. Our view is you should have both. There would be a really good route into government about having someone who can affect change, and also somebody with legal powers to some degree to challenge and to scrutinise. And look, there's charities like Age Scotland that try and do that, but we don't have to be listened to by the government or the Parliament. Sometimes they do, sometimes they don't. And I think that is an important element in public life, and something which could have more value. And I suppose it was hard to see, I'm not saying it didn't happen, it was just sometimes hard to see where older people figured in our sort of like human rights commission landscape at times. It was just slightly difficult to see, and it very well might have happened. Therefore, seeing what's happening in Wales, potential Northern Ireland, and of course they didn't have ministers for older people, but they're two different things. It kind of resonated that there would be, DNAR might have been higher up the flagpole in government if a commissioner was taking that forward. It may be compelling the Parliament to take more actions and activities to investigate when it could have, and it hasn't. That they can, and have in Wales, for instance, done a really good job of increasing the level of pension credit take-up amongst older people. Is a voice as independent of government can focus on issues that can tackle ageism and be listened to and heard and be respected in public life. So we believe that there is a strong case for this. But I don't think the mood of the government or the Parliament is to have any more commissioners. There have been various investigations into this, but you still feel that, irrespective of that, there's a really strong case for a standalone commissioner for older people in Scotland.
Thank you. And finally, is there anything we haven't covered that you would like to highlight at this opportunity?
I don't think so.
Okay, thank you very much. That concludes all my questions.
Thank you, Ms Bromley. And thank you, Mr Stachura, again, for your evidence. That's all for today then. And we're not sitting tomorrow or Thursday, so Friday morning at 10 o'clock. Thank you.